Good evening, everyone. My name is Teresa and I work for Medtronic. Tonight, I have the pleasure of hosting this webinar where you'll get to hear from Dr. Lal. Dr. Lal has been practicing medicine since 2000. He completed a combined BA and MD program at Boston University School of Liberal Arts and Boston University School of Medicine. He completed his internal medicine residency at McGraw Medical Center in Chicago, followed by a gastroenterology fellowship at Boston University Medical Center. Dr. Lal has a special interest in treatments for fecal incontinence, and he looks forward to discussing this more in detail tonight. Just a reminder, if you have any questions, please use the Q&A box at the bottom of your screen. With that being said, welcome, Dr. Lal.
Thank you very much. Can you guys see me now?
Yes.
Okay, you can hear me also. Okay. Um, I'm trying to get to the view. I've got this poll sitting in my middle of my screen. Yeah, there we go. It's gone. Okay, excellent. All right. Well, first of all, thank you everybody for taking the time out of your busy evenings to join us for what I hope will be a very educational uh, section tonight for you. Thank you for joining. So here's some thoughts that may be familiar to you. Will I ever regain control? Attend an outdoor celebration? I'm afraid to leave home. Will I ever be able to wear white pants again? How can I possibly go on a date? Get a job? The bathroom is always on my mind. It's embarrassing. So did you know that 54% of patients with fecal incontinence haven't even discussed it with a doctor? A large part of it is because they feel embarrassed and they just don't want to have that discussion, which is quite understandable. The problem is that when that happens, then the problem goes undiscovered. Well, I'm hoping to change some of that this evening with this information we're about to present. So bowel issues are not inevitable. They are common, and we'll talk about it on the next slide. It is not a normal part of aging to have problems with incontinence. It is true that it's more common as you get older, but it is absolutely not normal. In addition, it can affect both males and females, and there's a misconception that it's only a female disorder. Now, do any of these events sound familiar to you? Involuntary loss of stool, stained underpants, planning activities around the bathroom, stool present every time you urinate, using pads or protective garments. This can lead to significant problems with depression for patients because they have to change their daily events sometimes to kind of go around these issues that you're having. And these things, if you're having these problems, your body is trying to tell you something, and it's very important that you listen. As I mentioned earlier, incontinence affects people of all age, though it is more common as you get older, and males and female also are both affected. It's estimated that 1 in 12 adults in the United States suffers with fecal incontinence, which is a total of 21.4 million adults. Now let's put that into perspective. We just talked about how this is something that's relatively unknown and undiscussed. But we know about diseases like Alzheimer's and asthma. We probably hear about this all the time. We probably have family members who've been affected with these disorders. So would it surprise you to know that those are actually less common than fecal incontinence? So clearly there's a disconnect between the true prevalence and its awareness. Now, why is that? Why is there such a disconnect? Well, patients will often adjust their activities. They may enjoy eating a certain food, but notice that that causes them to have incontinence, so they'll avoid it. They may start to use pads. They may start to avoid social events altogether just to avoid the risk of having an event. Or they actually schedule their entire activities around the presence of a bathroom so that if they do have to urgently go, they know exactly where they have to go and they can hopefully avoid an embarrassing event. But it is very, very important to understand that you are not alone. And that is probably the most important thing I want you to take away from this presentation. Now, that's why patients don't really want to talk about it. But on the other side, you've got physicians and providers who aren't really great about proactively asking about these symptoms. So you've got patients who don't want to discuss it. You've got physicians who aren't really good at talking about it. And therefore, the problem goes under the radar and it never comes up and it can't be treated. Now, the major problem is that because of the embarrassment, there's a higher rate of depression in patients with fecal incontinence, as well as resulting in a lower quality of life. And these are extremely important endpoints that have been proven in studies. And many of you on this webinar today may very well be in that boat as well. So it is very, very important to understand that this is a serious problem, but more importantly, as you're going to learn shortly, there are things that can be done about it. So I want to take a minute to talk about what normal bowel control looks like. So this is kind of the basic breakdown is the GI system essentially runs from the mouth to the anus. And food gets eaten, goes down, gets digested, and then ends up in the colon as waste or stool. And when it gets to the rectum, what happens is that when the rectum gets full, it stretches. When it stretches, it activates the pressure sensors in the rectum. What then happens is that that sends a signal back to the brain telling you or telling your body, hey, we need to evacuate the stool. So there is the anus, which is a sphincter, which is a bundle of muscle that can contract or relax. It tells the sphincter to relax, and that allows you to have a bowel movement. Studies indicate that it's this breakdown in communication between the bowel and the brain that contributes to patients having incontinence. So I want you to keep this in mind because we're going to come back to this later. So what's the good news? The good news is that there are treatments available if you suffer with these problems that can get you back to living your life. These are divided into two categories, conservative therapies and advanced therapies. Some will work for some will work for others. But we're going to go through all the options now. So under conservative treatments, there's some simple solutions that can help patients. Again, it's inconsistent. Some may benefit, some may not. The first category is dietary modification. So for some patients, adding a fiber supplement as an example to bulk stool can be helpful in preventing some of these or reducing some of these events. Alternatively, if there are certain foods that may cause more events, for example, some patients may have more events after eating dairy products or spicy foods or fatty foods. And so then restricting some of those foods may be helpful as well. Then there's physical therapy. So some of you or all of you may have heard of Kegel exercises, which are these exercises designed to strengthen the pelvic muscles. That also can be effective for many patients, but not all patients. Then there's bowel retraining, also called biofeedback, where there's a formal physical therapist that can work with you to try to get your routine down so that you're having less accidents in terms of soiling clothes and such. And then there's medications, more commonly antidiarrheals, but often patients will do that and they may help. Others may have no response, or you have a new problem where you get constipated, and that creates a different issue. So for advanced therapies, we're going to talk about two main categories. We'll talk about surgical options, and then we're going to talk about our main topic for tonight, which is Medtronic's InterStim system. So for surgical options, so first, just to take a second. So imagine this circle just being a sphincter, which is a round bundle of muscle. That's what your anus is. So an intact anus is circular. If you have a defect in the sphincter where let's say it's like this and you've got a gap, that's one of the reasons why patients can have predisposition to leakage. So a sphincteroplasty, which is actually the second thing listed here, is basically just taking this and surgically repairing it so you have this. Post-anal repair is a surgery where actually the sphincter is intact, but there are other muscles in the pelvic floor that are useful in helping to maintain the ability to not soil on yourself. And if those are loose, they may need to be strengthened up and not the anus. And that's what that surgery is. There's also an artificial anal sphincter where they actually put an implant in, which is a circular implant to simulate the anus. And it basically has a pump with a bulb that you can use to increase or decrease the pressure. The other option is a colostomy. So for those of you who don't know that, what that is, a colostomy is basically where you would detach the colon from the rectum and you would bring it up and attach it to the abdominal wall. So the stool is coming out from the abdominal wall and you put a bag on the outside and that's where the stool is collected. Now that's beneficial in this scenario because it's bypassing the anus completely, so you don't get the leakage episodes. Now, like all surgical procedures, there's a lot of pain involved, but they still can be fairly useful in a lot of patients. Now, having said that, more recently, people are heading, or physicians, I think, are heading more towards the next option we're going to discuss, and that's reducing the number of surgeries like sphincteroplasties that are being performed. So now we'll talk about InterStim. So sacral neuromodulation or sacral nerve stimulation is the concept behind this. This goes under the name InterStim, made by Medtronic. And the premise here is that gentle nerve stimulation can help reduce the episodes of incontinence and urgency by correcting the communication that occurs between the brain and the bowel. As I mentioned earlier in that slide about normal function, that was the number one reason that we feel, based on research, that is where the breakdown occurs. Just imagine this analogy. Let's say you and I are sitting at a restaurant and we're having dinner, just the two of us, and we're right facing each other. But you're in a restaurant where there's a lot of noise. People, the restaurant are very loud. There's a lot of people there. Music's playing, and we're having a hard time understanding each other. That situation is analogous to someone with incontinence, where there is basically interference in that signal between them, in the communication. Now, let's say you snap your fingers and you get rid of all of that noise. And now all of a sudden you can hear each other and understand each other perfectly. So that's the analogy to what this stimulation does. So who qualifies for this? So let's talk a little bit about kind of the whole process behind this. Now, the concept of stimulation of these nerves is not necessarily a new concept. Some of you may have family members or other friends who have, or even just heard in general of things like spinal cord stimulators for people with chronic pain. For example, my mother actually has Parkinson's syndrome, and she tried medications, didn't respond. She ended up getting a deep brain stimulator. So it's a similar concept to this, except that's in the brain directly. Now, pretty scary concept of having to put a stimulator in your brain, particularly if you don't know if it's really going to work. Now, fortunately, it worked very well in my mom's case. But in general, I think for these kind of technologies, it'd be nice to be able to do a test drive. So that's the nice thing that they offer here, and that's actually where I'm involved in identifying patients who are good candidates for this technology, as well as being able to perform the test drive. So let's get into that a little bit. So to qualify for this, you have to have a minimal of 2 episodes a week. So when I say episodes, there's two main categories I want to elucidate. So the first is incontinence, which is leakage, whether it's with warning or without. The second category is urgency. So fecal urgency is where you get that sensation that you have to go to the bathroom, and if you don't make it to the bathroom right away, you're going to have an accident. Now, many patients get around this by orienting their activities around the presence of a bathroom or always being close to the bathroom. So it's still urgency because they have to rush to the bathroom, but they're just not having an accident because they're planning for it. So if you have at least 2 episodes combined between those categories a week, and you have tried the conservative therapies that we've already talked about earlier in this presentation, then you are a good candidate for this. So what the next step is, if you're a candidate, is the test drive. So the test drive essentially is a temporary stimulator that is on for 7 days. And Prior to this, we have you do a 14-day diary of your bowel symptoms to be able to quantify and get a baseline, and to also verify that you're having at least 2 episodes a week. Now, this procedure is done, I do this procedure myself. Basically, we have you fast after midnight. We have you come into our procedure center. This is done under local anesthesia, so there's no sedation. We don't have to put an IV in you. We lie you on your stomach and we put a pillow under your stomach to bring your hips up a little bit so we can prop that up. Now, the sacrum is the area basically right above the tailbone. So that's the area you want to work. The objective is to be able to get a lead, a little electrode, which is basically like dental floss almost, put it into the left and the right sides in the middle of the sacrum. So there's a third sacral opening where the nerve comes out. That's what we're aiming for. So we put the leads on in those two openings. And once we've confirmed that it's in the right place, we then attach the wires to a battery. And that battery communicates wirelessly with a smartphone device. That device is used to control the intensity of the stimulation. And those adjustments are made through the week. And we also test both sides individually, meaning we test the left side for half the time, and then we test the right side for half the time. The objective is to get at least a 50% improvement, meaning reduction in your symptoms from baseline. So again, that's where that diary at baseline comes important, because then we want to compare while you're doing the trial that you had at least a 50% reduction. And if you do, then that qualifies you for the permanent stimulator. Now, one of the things is that because this is a temporary stimulator, it's just bandaged on. So it's not, it's not sutured in, it's not placed, the battery is not placed under the skin like a permanent one would be. So it's important we advise patients to keep the bandage dry. So you want to sponge bathe as opposed to showering for that 1 week. And try not to do too many physical activities like jumping, bending, because we don't want the leads to dislodge. Because if they dislodge, they'll no longer be near the nerve root where it needs to provide stimulation. So you come back to the office a week later. We remove them. It's just simply pulling them out. Very simple process. And then you're recording the symptoms on that smartphone device that I mentioned earlier. And so we record, and we review and we compare. And that's when we make a final determination at that point. So I'm not going to spend too much time on this. Basically, this is just a demonstration of the app on that smartphone that you're tracking your symptoms, but also has other information that's helpful. So just to kind of summarize, so what makes you a good candidate for this system? Well, InterStim is good for you if first you have chronic symptoms, at least 2 episodes a week of incontinence and or urgency, as I discussed earlier. You've tried the lifestyle changes or oral medications, and those have not helped to your satisfaction, and they have not given you the relief you want. Now, if this describes you, then this system is the right option for you to consider investigating. It is a proven therapy. It's been around for quite a number of years. It's been around since 2011. Actually, it was originally approved for bladder incontinence, actually. So the other thing I didn't mention is that if you happen to have bladder issues as well as fecal incontinence, both symptoms can potentially improve from this stimulator. So 89% of people who use the Medtronic bowel control therapy experience long-term success. And again, we're talking about at least 50% improvement from baseline. And this is actually even a higher percentage than for bladder. Studies have shown that these patients have achieved significant quality of life improvement as well. And they're able to get out and do the things that they've not been able to do for a long time because of the things that we talked about earlier. And there's been over 425,000 implants placed over 25 years. So it's definitely a very safe, effective, and proven system. So this is a patient who underwent this, not my patient, but a patient. And they were quoted as saying that I can do so many things I want with less worries. This is so empowering. Now, while this is not my patient, we do have a special treat this evening. We have invited And I'm happy to hear that she accepted an invitation for one of my patients, a wonderful lady named Susan, who I saw for this problem. And she underwent both the test phase with me, and then we sent her out to have the permanent implant done. And I am actually going to let her tell you her side of the story and let you know what she thinks of the system.
Thank you, Dr. Law. It wasn't that long ago. In fact, I think it was last May that I too was invited to the webinar, and I'm retired now. So I thought, well, why not? Let me see what's going on. And I listened intently and thought, if this could change my life, I am very interested. Because actually, looking over the previous slides, I had done many of those things, diets like you couldn't imagine, different medications, and my life continued to actually get worse with the amount of incidences that I would have. My job, which I had just retired from a couple of years ago, was one of travel. As you can imagine, if you are sitting here in this webinar, it's a hard thing to travel on a plane and have to go to the restroom when they're on takeoff, and you just get into some kind of like a panic mode. So I was all in. I didn't have 2 accidents a week, but it was because, like Dr. Law said, I was creating my life around access to a bathroom, which really isn't a way to live. I wasn't exercising like I wanted to. I couldn't walk around the neighborhood. I couldn't go hiking. I couldn't do anything that required any length of time to be away from a bathroom. So I was all in. Didn't quite understand it at first, as he'll tell you. I asked him about 10 times about the brain stimulation, but I wanted to discuss it further. So I got an appointment right away. And the appointment itself, I don't want to embarrass you, Dr. Law, but it's not an easy thing to talk about, but you made me feel so comfortable and that there was an option out there for me, which I really didn't think there was at that point. So I was in. He said that, 50%, I would have gone for it and said 20 because it would have been an improvement. But we had the trial week. That to me was harder than the other one because I couldn't take a shower. But the actual procedure itself was painless. I wasn't having any accidents and then he told me that it would be a temporary thing because it was a trial period. And once it was removed, I'd go right back. Well, that first week, well, the only week that I had the trial in, I actually ended the week by going to a concert that was 2.5 hours long, and I never had to get out of my seat. It was just so wonderful. So I went back and I said, I'm ready for the real deal. That was easy. Everything he said was absolutely true. The support from Medtronics was awesome. I was a little anxious about the computer part of it. I haven't had to touch that thing in 4 months or 3 months since May, once it was put in. I've Everything's just been great. I say that most of the time I'm 90%. The 10% is actually not an accident. It's just more my anxiety, not being able to rid myself of the past memories. But the longer I go with this implant, the better it gets. And I have my life back.
Excellent. Well, that's fantastic. And I'm very glad to hear that you had a great outcome and happy that happy that you watched the webinar. That's the
That's right.
important part that we were able to help you change your life. That's great. Excellent. Well, thank you for those words. Really appreciate your time and for joining us also as well.
Thank you.
So basically, just to kind of tie things up, the process for anyone who does feel they would be a good candidate for this is to make an appointment with us. Now, I specifically am the only one in the practice who actually does this, so you will want to make that appointment with me. Specifically, my information is on the screen here. You can call the main number at 678-741-5000 and go to the appointments line and make an appointment. Or you can go to our website at gigeorgia.com and you can register there through the patient portal and you can make an appointment as well. And I look forward to meeting all of you or whoever needs help, and we're happy to help any way we can. Thank you very much for joining us this evening. I know you all have busy, I'm sure you're all busy, and thank you for taking time out of your evenings.